Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today on the show, I'm joined by Margot Morton, CEO of CareZen. G'day, Margot. How are you?
G'day, Pete. Welcome home.
Thank you. Yes, no, I feel like it's great to be here back in the studio recording a conversation with yourself. And I think last time we were on the podcast, it was 150 years ago in different organizations, very different world then too. So, but there has been a lot of conversations in the THD Plus community and just generally out and about that we've had. So it's great to be able to consolidate some of that and share with the, someone at home that is keen to learn more about accessing care in different ways, because I feel like we're going to dive into a lot of that today. Firstly, can you introduce yourself and a bit about CareZen and what you do, and we'll go from there.
Yeah, cool. Thanks, Pete. My name's Margot Morton. I'm the co-founder and CEO of CareZen, which started 15 months ago from my kitchen table as we registered a business in ASIC. And CareZen is creating and building safe private spaces to connect to virtual care. For those in Australian communities that can't connect at home, the pod enables a safe place for them to connect to care.
Excellent. What does that look like? Because when you say connecting to virtual care, we're all very familiar with accessing telehealth services when you can't physically, or when maybe you don't need to physically access a clinic. Tell me more about what that pod is and what it looks like for those unfamiliar.
Yeah. So basically, in a previous life, I rolled out quite a lot of virtual care programs. And what I saw, particularly in regional, rural, and remote Australia, that scanning a QR code and sending a patient out to the car park with their phone pointed at the sky, trying to connect, was not ideal. I also saw, wheeling in a big chunky telehealth cart took up a room, which you could see the clinicians and the nurses and the team were going, I actually need that room. Thanks very much. Get your telehealth cart out.
Wait, for those even unfamiliar with telehealth carts, because you talk about these things like they're because you're embedded in this world, but the telehealth cart, so it's computer on the ability to do telehealth within the clinic to then connect with patients. Is that right?
Yeah. So basically, they call it a cow or a wow, workstation.
I don't think we say cows anymore. I don't know why we stopped saying cows, but
really?
it might have been offensive to cows. I'm not sure, but
well, they call them wows.
Hopefully that comment didn't get me cancelled. We'll find out. But sorry, continue.
But we saw the wows, the workstation on wheels, right, for a telehealth consult be wheeled in, which was great. You'd get a virtual emergency specialist or a virtual specialist on the screen. And Fran had come to a nurse-led clinic and she was having a consult with a doctor on the screen, which was great. Mm-hmm. And guess what? In a population of less than 3,000, Dan was behind the curtain on the other side and he heard the whole consultation, right? So there was a lack of privacy, a lack of confidentiality. And by 3 p.m. that afternoon at the IGA, everybody knew what Fran had presented for. So even though that's quite comical in itself, but what it led to is an aversion to seeking healthcare. So Fran would hold on to what she went initially because she didn't want everybody to know. And she'd only do it when she went to the city, which was probably twice a year or 3 times a year to see her doctor. So we saw that there was a need for a private, safe space where patients who were ambulant, could walk or wheel themselves in, could actually access a virtual care consult. So during COVID, I actually did quite a large paper on pods because we could see pods was the answer. However, there weren't any pods on the market that would meet National Safety Quality Health Service standards, so the NSQHS standards, nor any pods on the market that would meet the Australian Health Facilities guidelines for infrastructure. And the main reason for that was infection control. So just as you have your soundproofing in your studio, right? Mm-hmm. The office pods actually aligned with the flocking, like a carpet material. So they've got their acoustic sound, not quite soundproofing, but acoustic qualities. But if you have a pathology background and you cut one of those squares out and you send it off to the lab, you'll find that it's full of pathogens and
Oh,
bacteria from the last person who sneezed and coughed in there, right?
mm.
So I can see your face. But
I'm wondering what's in these walls behind me, but continue.
so none of the pods that were on the market was suitable, right? Um, but they had the right sort of framework, but they weren't suitable to put on a health precinct
Mm.
or to put a patient in. Um, and so we went about trying to find a builder who could build us a pod. And we built this prototype with a builder who had actually built lots of modular emergency departments, things. Fantastic guys, group of guys, Australian builder, so it's all Australian made. And we built this really ugly prototype that looked like Houdini's water closet, right? This great big thing. But it was accredited. It was great. It
Mm.
was built to standards. It was like a little mini hospital room. It was modular. It was wheelchair accessible. And intuitive touchscreen technology. So we built all of this and put it together, and then took it to Digital Health Festival Week a year ago, May
Mm.
2024.
Yes.
So yeah,
And so, got it. So, yeah, you've got the modular room, the Houdini's water closet, as you mentioned, but functionally appropriate, and that sounds critical. What does it look like? I saw it recently. It does not look like that
no,
at all from what you've described. Talk to me about that journey of getting it from, like, I guess, the prototype from where you're at
mm-hmm.
to where we're at now.
Yeah, yeah, thanks. Look, yes, we could see that it was ugly, and we could see it was 650 kilos, not
Wow.
exactly deployable really easily, right?
Mm.
We needed to change the design on the inside. We needed to make it more lightweight. We needed to have the measurements for ISO standards for acoustic soundproofing. So we needed to change quite a lot about the pod, and we wanted it to look aesthetically pleasing, modern and with a nice aesthetic that any hospital or new or old hospital would be happy to have it in their foyer as something that patients could access. So we spoke to over, gosh, I think the final number of feedback that I had was 2011. So we spoke to over 2,000 clinicians and consumers, and we took them through, what do you think of this, and how would you feel safe, and what about this, and so we gained a lot of feedback in the next design, and so with our brilliant naming rights, we called that Next Gen Pod.
Oh, okay. Yeah, right. Got it. Yeah,
Next
clever.
Gen.
Claire. Yeah, CareGen. Zen. Um, and so you mentioned hospitals and the, in the foyers. I'd love to learn from you where you picture these things going, because I've done it was a few years ago. I was in a Westfield shopping center, and there was like it had nothing to, but the closest thing I can think of what you're talking about is kind of like, do a full body scan and it gives you something, and you go, oh, that's kind of neat.
Mm,
And I've heard people talk about, oh, we need a like a mini clinic in a wherever you can access care, and shopping centers sounds like an obvious one, but then you talked about hospitals and clinics and things.
mm,
From
mm.
your side, where do you picture these as being most appropriate to be deployed?
Yeah, yeah, thanks. I think there's a few steps to go before we end up in Westfields or airports or train stations or things like that. One, we built them so they could be on a health precinct with national safety quality health service standards. So the pods actually meet accreditation. Now, I don't know about you, but when I've walked into a hospital and they're going through accreditation, that's the time you turn around and you come back when it's over,
Mm.
right? So there's a nurse unit manager with a clipboard somewhere or an iPad, and she's going, get that out of my hospital. Doesn't meet my accreditation standards, right?
Yep.
So it was really important that we built to those standards. And on my roadmap for the next 2 years, I would hope that they're connecting people to virtual care within a healthcare environment. Now, whether that be a model of care for outpatients, so country people don't have to travel back to the tertiary facility for their pre-admission checks and their post-operative discharge, that they can do that virtually from a virtual care pod at their local health service. or whether that be virtual allied health, so virtual speeches, virtual OT, virtual mental health, or ADHD assessments for littlies. So the pod can work in a hybrid model of care in that environment. Again, I had a recent conversation about having pods uh, on Bamaga Island and right up north in the Torres Strait. So women and children could stay on country and they could do virtual breastfeeding clinics from the pod. So there's lots of applications for people to have a private, safe space to connect to care. And I really do see what's really important to me. And one of the reasons why my co-founder and business partner, Megan Dedell, and I are bootstrapping this is so we don't get the ways of an investor saying, why aren't you putting them in Westfield, right?
Mm.
We really want to hang on to this, that we get at least the first 4,000 patients through with zero clinical incident. So if there is a clinical incident, we want them to be on either a health precinct or in a community centre or a library where there is medical escalation pathways available, right?
Yeah.
Zero clinical incidents in the pod so far, and we've had over 600 patients go through. So we're starting to get some really solid data around clinical safety and
Yeah.
appropriateness in the pod.
I'm keen to learn about those that have utilized it already and those kind of settings and how that's going. But just to actually, I can't pass over this. When you mentioned the accreditation, I had flashbacks of when I ran clinics and we were going through accreditation and we had to check the expiry date on the toilet paper in the storeroom. And I wasn't aware that toilet paper expired, but that was on the list to check. So as long as you haven't got toilet paper that's expired in the pods, then that's a good
I
safe bet.
told you there's someone with a clipboard somewhere that will kick that out of the hospital.
Right. So the accreditation side is super important though, and I would imagine from a hospital or a clinic's point of view in or anyone implementing this, having that kind of peace of mind, I guess that it's
Mm,
that's not an additional burden to carry necessarily, or at least it's
mm.
something that's there. Who are the when you talked about though the accessing care in different ways? So to be clear, I guess the service or the thing that you're providing is the infrastructure, the capability in order to deliver care. Because it sounded like there's some examples where it could be a hospital setting where they're like, so the doctor or the medical professional that the patient speaks to, are they provided by you? Are they provided by the hospital or the clinic, or do they connect in with other service? How does that kind of look?
Yeah, cool. In actual fact, this is the beauty of the product, I think, anyway. And if you do your research on pods globally, a lot of the reasons why these companies like 4Health have foreclosed um, in their in
Good
in their
branding.
design of pods. This is a US company. Is because they tried to provide the doctors as well,
Right.
right? I believe it's a big mistake. So therefore, what I have is very simple, intuitive technology with a Windows interface, and I am agnostic to platform and agnostic to service provider, right? So really, mine's very, very simple. If it's going to be a statewide virtual service, you just provide me the URL through to your virtual service, and I'll put a big button on the screen that they can connect to that.
Hmm.
Right. So, and it just goes through to that service. If you would like your allied health and you would like speech pathology and OT and ADHD or mental health assessment and a GP, it is just a matter of buttons on a screen for people to tap on. Really interesting in Rocky. We know these stats, we know the digital literacy and numeracy and literacy levels, particularly with regional Australian and vulnerable communities. We know them, we read those stats all the time. But when I did this pilot in Rocky with the pod, it was in my face, right?
Mm.
We take for granted that we can fill in 6 or 7 pages of online Margot Morton, and this is my phone number, and this is my
Yes.
email address. We take all that for granted. I would say, out of the patients that I had, I'll have to look it up, but I would say easily 1 in 4 needed my help to enter the details.
Mm.
Some of those patients knew that their Medicare card was their green card and
Yeah.
they needed that. But ask them to enter all the details, it
Mm.
wasn't going to happen.
I want to learn about the Rockhampton. So it's a Rockhampton pilot. It sounds
Mm-hmm,
like, or the
mm-hmm,
implementation of the pod. Fun
mm-hmm.
fact: I was born in Rockhampton, so I'm well familiar
Really?
with Rocky. And but that's so even more interesting for me to learn about. Talk me about like what's happening there.
Mm. Yeah, so we did, it was a great collaboration between Queensland Health, CQHHS, and driven by the CCQ PHN, Julie Sturgis and Tim Garden, the key leaders up there for CCQ PHN. Amazing. So they did the collaboration and it was to support primary care, particularly over those public holiday seasons when there was a shortage of GPs in town. And hence, what do we do when we can't get to see the GP? We go to the ED, right?
Mm.
So we saw a number of patients. So we had a very clear inclusion criteria. We worked with the ED team and it was a patient choice architecture. So they were offered the choice. Absolutely, you can sit and wait for the doctor, but there may be a considerable wait, or you can commence your care today in the virtual care pod and see a virtual doctor. What we saw was potentially the majority of patients were, I came here to see a doctor, right? And then about 40 minutes later, it was like, what are they doing in that box out there? I want to go into the box,
Mm.
right? And so we started to see the patient choice architecture was super important, and that as long as they met the inclusion criteria, which was obviously low acuity patients, they could commence their care virtually. Out of all of the patients, only 6% were referred back to in-person care back into the ED, which was, like I had this beautiful old Albert fellow. He came to me with an ankle laceration. He's on warfarin, and I was like, yeah, nah, not in the pod today.
Yeah.
Back to the ED.
Yeah. That's interesting. I'm keen to learn about that more too. Like and I guess you have touched on quite a few examples already. Like
Mm,
that. How do you deal with determining the right kind of consultation that would take place in a pod? Because as
mhm,
you that makes it a lot clearer too. Like you said, you wouldn't just go ahead and put this in a high traffic area or anyone can kind of just go in and have any kind of health service. It sounds like it's for a particular cause. In that example, if you could take pressure off the ED because there's not enough access to outpatient care and there's a
mhm,
large percentage of people sitting in that ED that could
mhm,
potentially have a consultation,
mhm,
they're already there, but then in a
mhm,
physical different spot, that takes a lot of pressure off the
mm.
system. Are those the kind of situations you see that right now that's a good application of the pod?
Yeah, look, that's actually where I started. That's
Mm.
that's where Megan and I actually thought the issue was. Um, and yes, that would be a great application. What we don't want to do is we don't want to put pods at EDs and then people make their way to the ED. We don't want to increase traffic to the emergency department.
Yeah.
We want to educate the community that the emergency department is for exactly that, when it's an emergency, not when you can't access elsewhere. So I'm a big believer, and this was a lesson that came out of the Rockhampton one, is that potentially we could put it for low acuity cases. So, it could be in a library for women can go to the library and seek psychological safety or have a consult to report domestic violence. A lot of the time, that vulnerable patient can't go to the doctors or can't go to the hospital, but they can go to the library. So
Mm.
the pod would be ideal there where people could connect to care. Um, and community centres. And 70% of our country is in some sort of disaster zone um, at some point in the time of the year and cut off from healthcare. So being the pods agnostic to platform, agnostic to service provider, we connect everything so everyone has low Earth orbiting satellite system, which is Starlink, but Elon's a bit on the nose, so we don't say Starlink. so, and so it's completely connected and can be deployed. So, for example, Lismore, when they get cut off, we can deploy a pod. It can be turnkey. We can have RPA virtual through Health Direct
Right.
on a URL, and patients can connect to care. So that's where I see that application that can really help the community be a
Yeah,
self-serve.
totally get it. I can see a lot of value there.
Mm,
What does that look like for health systems implementing something like the pod? Because I feel like the current sentiment amongst the vendor community, or amongst the providers of technology, or even new workflows, is that we're a bit over pilots, and just dipping the toe, and we say, let's it's not really worth having a go unless you do a pilot, because then the argument to doing a pilot is they don't have skin in the game and there's no kind of commitment to the thing. But at the same time, I couldn't picture a health system, just
mm,
putting in a number of um, pods, which is, I guess, a new model of delivery for
mm,
them. It kind of, if
mm.
I was a
Well,
CTO or a chief net, whoever, um, that's probably not the approach I would take. What's your take on what's the best way to implement something like this?
yeah. So I've been doing this for 30 years, right? Finding buckets of money for my clients. Like, let's find the money. Where is it?
Yeah.
Right? Let's play that game.
Mm.
Um, and look, we have to start with pilots, particularly with innovation. We have to. Like, I know vendors and people don't like them, but we have to. We have to be able to evaluate and make sure that we're spending money appropriately and it's getting the results that we hoped, that we thought it would achieve. So there's two things here. One, what we've done is we've put a commercial model together that somebody can lease a pod for 12 months. So we'll deploy it, we'll manage it, we'll connect it. You just give us the URL through to your clinicians of whatever you would like to use, and then it's just an OPEX bucket and minimum
Mm.
of 12 months. And then, because number of these pilots, and then we do the evaluation, what we've done is we've actually built that you can do real-time evaluation. So every pod, all the patient experience data, all the utilization data of how many consults, time to wait, length of consult, presenting condition and outcome, whether it was a repeat prescription, a med cert, or referral, or antibiotics, or whatever it was. All of that data we actually pull back, it's not difficult, into a dashboard. And so the client can log on and see, oh, I've had 10 patients through the pod in Rocky today.
Yeah.
Oh, their patient experience data was all exceptionally high, was 95%. So that way, at any time, when the CFO and the CTA goes, how's that pod going over there? You can go, oh, which pod out of my fleet? Oh, I can see that, yes, Hastings has done 10 patients today and everybody's happy. Or I can see Rocky went offline at 10:30 for cleaning, and we'll be back online at 2:30. So we have it all connected so they can actually evaluate in real time, instead of doing an evaluation at the end of 12 months and paying all that money and finding out that it didn't work, right?
Yeah. So that's super important, I think, in just providing that reassurance and the communication back into the business
Mm.
too, on like what this
Mm.
investment or this lease is, and should we start thinking about ramping up. And so that would mean then you'd have some insights into that Rockhampton pilot. Are there any
Mm.
stats or I guess results to date, or interesting things that you can share with us that
Mm.
have come from utilizing the pods in Rocky?
Yeah. Well, the biggest one that I thought was so good, I'm so excited about, is out of the patients that completed the feedback, 34% identified as our First Nations community,
Hmm.
which was great. Um, Out of that 34%, 99% of those patients had not ever been able to access virtual care before, had never tried virtual care
Hmm.
before. 88% of those patients said that they felt comfortable in the pod and that they would use the pod again to access virtual care. So I did not realize that. That was when I started to see the cohort of patient that we're capturing in the pod is those that we have never been able to capture with 1-800 numbers or QR codes or links or anything like that. This is a patient that really embraces virtual care that we've never been able to access before to capture with virtual care. So I just, that's probably the biggest eye opener to me.
That I think is, probably the biggest call out from the conversation, I guess, in that
Mm,
I mean that's so often we talk about on the Talking Health Tech podcast the issues that we're addressing with technology or that
mm,
um, aren't the ones that the communities need, and
yeah.
but what you're talking about is uh, providing access to appropriate levels of health care to people not otherwise able to access it, particularly
Mm,
communities of need and Aboriginal and Torres Strait Islanders. So
mm,
I would love to see that number continue out as the pods scale out too. So I can see why that would
mhm.
continue to drive you on a day to day through all the ups and downs of
Yeah.
bootstrapping a solution. So yeah, definitely going to be watching that with interest. And so what does that look like then ongoing now? And like, what does that future
Mm.
look like for you? Where are your priorities over the next kind of 6, 12, 24?
Yeah. Well, basically, as I mentioned, I want to make sure that the pods continue to improve access to healthcare because we know that regional, rural, and remote Australians actually are the ones that bring us our agriculture, bring us our mining, bring us all the things that us city folk take for granted. Um, and for them to stay out there doing that, we need to make their places more livable. And how we make them more livable is access to health and access to education. Now, I haven't got a plan for accessing education, but I will later. But
Us too.
accessing healthcare, I think if I can drop in deployable, connected pods that are intuitive and easy for people to connect to care, then that is absolutely my go-to plan. I would like to make sure that I have another, over 2,000 patients that have gone through with zero clinical incidents. We've had zero clinical incidents, so it's really important to me that the pods are safe. And then once we have done that, I would also like to work in education and make sure that we can put education in schools for hybrid models of allied healthcare, for speeches and ADHD assessments, all those things that all these littlies are waiting until they're 35 to get at the moment. Um, and then eventually, yes, we will probably, once we know that they're safe, yes, you'll see a pod in Westfield and at the airport and at a train station. But going slow, going well, going deep, sticking to standards, making sure that the patients are at the centre of everything we do will keep us honest. And I haven't got any investors to answer to, and I don't want any either. So it actually keeps us on track on our mission. So it's good.
Yeah. And I feel like that, you're in all the conversations we've had, Margot, hearing you kind of take the feedback on board and that's helped shape where the direction, you've got that guiding star or whatever in
Mm,
terms of
mm,
where you're going, but as that evolves and as more patients go through the pods and different scenarios come up, then that'll no doubt help you continue to grow as an organization too, and the offering you provide.
mm,
But look, I hope too that this conversation then opens up the minds to others within the health setting of like what that kind of model of care needs to look like and how to
mm,
address problems, and potentially
mm,
something like a pod could help address an issue, or even just helping problem solve that a bit more. I know you're always
mm.
good for a chat, Margot, so I'm sure people know will work out how to get in touch with you off the back of this. The details will be in the show notes of this episode. So I really appreciate making the time, having a chat on the podcast finally, Margot. Looking forward to seeing you
Mm.
out and about again soon. Thanks so much for your time.
Yeah, thanks, Pete. And thanks to all the Talking Health Tech people. Without them, I wouldn't be where I am right now. So I'm so appreciative of the community. So that's
Love
good.
it. Thanks, Margot.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.